And welcome to a crash course in assisted reproductive techniques. My name is Dr. Griffiths. I'm speaking to you from the Chaminade University of Honolulu, so aloha and welcome. Today we'll be talking about reproductive technologies in which sperm and egg are removed from the male and the female individual and are then going to be processed in a laboratory and put back into the female either pre or post fertilization. So infertility is defined as the inability to conceive a child after 1 year of attempts. Subfertility means that the couple is able to conceive in that 1 year time frame, but is going to have a much longer time frame than a normal individual, a normal set of couples. We have about 30% of the cases are going to be male infertility, and about 60% are going to be female infertility, and approximately 10% are going to be what we call idiopathic, or that we don't currently have a reason for them at the moment. This is going to be very common. Approximately 1 out of 6 couples has difficulty conceiving children, and so therefore it's very common in the developed nations to reach for something like assisted reproductive technology. In fact, in the past 40 years, in fact it's been 42 years, since Louise Brown was born, which is our first IVF baby, we've had over 8 million individuals brought into the United States through advanced fertility treatments. So it's a very common procedure. One of the ways that they'll do this is artificial insemination, where they'll take donor sperm and collect it, and they'll be able to concentrate it, which is very helpful if we have a low sperm count, and then they'll pull it and paste it back into the female. If the male has very low sperm count or is unable to give a viable sperm, for example, perhaps he's had testicular cancer or had his testes removed or had undergone chemotherapy or something like that, you can get donated sperm from sperm banks. We also have in vitro fertilization, which is when we are going to take the egg and the sperm from the male and the female, and we're going to combine them and allow that developing embryo post-fertilization to develop for about 4 days before being implanted into the female. And this has been quite successful for females who have blocked fallopian tubes. So they have good good egg quality and good uterine quality, but they're unable for the uterus to actually receive the egg because the fallopian tubes don't function properly. We are also able to have something called gamete intrafallopian transfer, where we take the eggs and the sperm, we collect them, and then without allowing the fertilization event to take place yet, we take it and inject it back into the woman's fallopian tubes, where fertilization can take place in a more natural setting in utero. If in the case of having a very, very low sperm count, or low sperm motility or bad sperm morphology, we can take a single sperm that has good DNA. So as long as we have the integrity of the DNA is still intact, we can take that sperm and inject it directly into an egg. So the sperm has absolutely no barriers to fertilization. So it doesn't have to swim through the cervical mucus or deal with any of the acidity in the vagina or actually get through the cumulus cells and penetrate into the egg to actually fertilize. It can just be put specifically into the egg and then allow, after that fertilization event to happen, allow the individual to mature. Now, reproductive technologies have had great positive impact, specifically on couples who have difficulty bearing children otherwise. It's also had great impact in animal husbandry, so it allows us to improve animal breeding techniques. We also are able to use the frozen embryos if they are donated, so once the family has decided that they may max out on their family size but still have embryos that are frozen down, they can decide what to do with them. One of those choices is to donate them for stem cell research and also gene therapy. And additionally, we're able to, in the case of a couple who has offspring that already has some sort of genetic defect, they're able to have a secondary round for when they're having their second child, where they have something called pre-implantation genetic diagnostics, whereby they can eliminate the genes that are going to be defective, eliminating the embryos that carry the genes that are going to be defective, so that they will end up with a second child that is healthy. However, there are some negative impacts because this is one of those areas where the ethics hasn't quite caught up with the biotechnology yet. So there are a couple things that could happen that we want to make sure don't happen. For one, we want to make sure the embryos don't end up getting mixed up. We also want to make sure that surrogate mothers are going to be clear in their role, and they're going to be signing documents indicating that they're going to be handing the children over at the end of the pregnancy. In case of changing their mind, however, that children actually are going to belong to the surrogate mother until that paper is signed. So there's a little bit of a question of over who owns the embryos, or for example, a husband and a wife have created the embryos and they end up in a divorce situation and they want to know who gets to take the embryos and what gets done with them. Additionally, there's a little bit of inequity that can occur here because this is going to favor the couples that are going to have access to insurance plans. So generally it's going to favor middle class, heteronormative, married couples to be able to allow these techniques. So this is going to have a little bit of inequity in that regards as well. In terms of fertility testing, we're going to check the male first. It's easier, less costly, and less painful, although it's also less likely that it's male-related, to obtain the sperm than the oocytes. First, we'll check for their shape, their motility, their morphology, and their number. A gynecologist can check the female as well to make sure that her reproductive organs are present and functioning. Generally, male infertility is going to be easier to detect but harder to treat, and approximately 1 out of 25 men in the United States are going to be infertile. Some of the causes of that is going to be a low sperm count, including anything that's going to be 120 million or less sperm per ejaculate. We can also have hormonal imbalances, but generally things are going to be related to sperm quality and motility. Now, sperm count is no longer as big of a deal as it used to be. Sperm can be concentrated now, and so we can get our sperm numbers up pretty high from multiple different samples. However, low motility is going to be more difficult to treat, and this might require intracytoplasmic sperm injection, where the nuclei just pops directly into the unfertilized oocytes. In terms of female infertility, I'm not going to get into everything that is an option, but there's a ton of causes, so multiple causes. It can include erratic ovulation, blocked uterine tubes, things like endometriosis or tumors, also pelvic inflammatory diseases, and sometimes we can have anti-sperm secretion, so antibodies that are actually going to attack the sperm that are found in the female reproductive tract, and of course advanced maternal age. So for female infertility, another thing that complicates things is that sometimes early pregnancy loss, which can become more and more common as women get older, can actually appear to be infertility because those early fetal loss events might not be detected, and your bleeding is going to resemble a heavy menstrual flow, but you would just assume that you had a very intense period, and you might not necessarily know that the fetal loss event had actually taken place. Additionally, when we go through these course of fertility treatments, oftentimes fertility drugs are meant to stimulate ovulation, which means that we're going to end up releasing multiple oocytes, which often means that we can end up with an increased risk of multiple birth. So not just having one child, but having multiple children during the same reproductive event. Now, women who have no ovaries, for example, ovarian cancer, or have had blocked fallopian tubes and had to have them removed because of ectopic pregnancies or something like that, they can use a donor oocyte for their pregnancy cycles. Additionally, if a woman has a uterus that is unhospitable, she can choose to have a surrogate mother carry her pregnancy. So basically another woman is going to carry the baby to term for the woman who wants to actually be the mother. The custody rights are going to be given up at birth. And again, this is a very tricky thing because until that document is signed, legally that child is actually the offspring of the surrogate mother. So once those custody rights are handed over, then of course the child is going to be given to the mother who actually donated the eggs. There's a lot of legal and complex emotional issues here that have to be considered, in which most cases surrogate motherhood agencies won't actually accept a woman for surrogate motherhood until she's approximately 28, because the younger a woman is, the more likely it is that she's going to change her mind towards the end of the pregnancy. Additionally, sometimes the surrogate mother may actually have contributed that oocyte, so genetically that offspring might be hers as well. So there's a lot of different variabilities and also complications that can arise from these advanced reproductive technologies. Another interesting thing I'd like to bring your attention to is something called a savior sibling. So sometimes parents will have an offspring that has a problem or a genetic disorder. So for example, Molly was born with Fanconi anemia. And so Lisa and Jack, her parents, sought to conceive another sibling. They did, Adam. They used something called pre-implantation genetic diagnostics to select a sibling that would be suitable. So he would be a match for Molly. And approximately a month after her birth, physicians were able to take the umbilical cord stem cells from Adam, put them into Molly, and cure her of her anemia, which is a fantastic success story. However, oftentimes these genetic problems require a lot more than one transplantation, right? So one of the issues that can arise from these savior siblings is obtaining consent for a child that's going to be used in a medical treatment plan for the sibling. For example, some of these children are going to be under 1 year old. They're going to be very, very young, and there are going to be risks of these surgeries to the siblings. And additionally, if we have the right to select for certain traits, where do we draw the line? So if we're selecting for a particular composition that will allow you to be an organ donor, for example, for your sibling, how is that any different than selecting for a particular eye color or intelligence or height? And so if we're able to select for or against certain things, at what point do we actually enter into the realm of human genetic engineering? It is quite a slippery slope. So I'm going to end my lecture here, but I just want to flip through a couple more slides just to demonstrate to you that I have a couple examples that also you can use as a springboard for some complicated things that went wrong, because again, this is an area where the ethics have yet to catch up with the biotechnology. So I hope that you've learned something, and I really appreciate you coming to my class today. I'm going to open the floor up for any questions you might have. Have a fantastic day.